So here I am. There were 3 questions, 3 talking points. I'm going to talk a little bit about Virginia Health Information, give you a little background. I'm going to talk then about the all-payer claims database, both nationally, how they're formed, a little background on that. I'm going to talk about a little more detail about Virginia's APCD, how that came across, and then I'm going to try to address these questions in relation to how you can use information to specifically get at those different concepts. So I also work for a board, just like Eileen and Barbara, in that we're an independent nonprofit 501c3 organization. We've been around since 1993. We were formed in response to stakeholders' desire to have state mandates for certain healthcare data reporting, but they also want to ensure active involvement by all the different stakeholders. So all the laws associated with this have been written in a way that there is a state authority for these things, but then they are executed through VHI, through the stakeholder groups, through that. That's what provides broad input that we have today, and that actually then helped lead to where we are today in development of the APCD. So there's my board members there. They come from business. The single largest group is from business members, 5 business members that are nominated by various associations, including the Chamber, the Manufacturers Association, and the Business Council. We have 3 consumer, self-nominated folks that come on, and then 2 each from the hospitals, Medical Society of Virginia, Association of Health Plans, the nursing home associations, and then we have health plans, and we have 4 members associated now with state agencies, State Health Commissioner, Insurance Commissioner. We also have representatives from the Joint Commission on Health Care, and then finally the State Health Commissioner that we have on the Board of Directors also. So we have 4 of those. It's a very active group, very involved, and very diverse opinions. So why am I here? What do we do? We're around here to create and disseminate healthcare information and promote informed decision-making by consumers and purchasers, and to enhance the quality of healthcare delivery. Here's some examples of some of the things we do. Over the years, we've broadened out with the hospital discharge data, then broadened out to nursing home information. We have a series of consumer guides, as well as other information on patient satisfaction, nursing home quality, cardiac care, obstetric care, and all those things. All those things are free and given away on our website. We do have large-scale databases that are acquired within Virginia and across the country, as well as smaller databases that are specific to certain things. Maybe they have to do with nursing home financial or ambulatory surgical or hospital financial and operational information. Other things on the licensing information associated with hospitals, and others apply for licenses to operate on their structure and on their performance. So I'm going to shift into a little thing. So I'm going to show you a couple of things that we currently do now. And then on the yellow tabs, you'll see below, are how we believe they could be enhanced with the all-payer claims database. So right now, Virginia's health insurance and most health insurance companies give us their average allowed amount for a group of 31 procedures or services. Have anything to do with different surgery or preventive health care, doctor's office visits, deliveries, radiology, and other things. Their average allowed amount is how much they allow. Okay, that doesn't include that's the overall amount. So we get that information, we then average that, and you can get additional information then on what you would expect to pay. So that could be a facility cost, could be a physician cost for radiology, and all those things, and we add those up, and we have that. With the all-payer claims database, you can go deeper because you can get additional procedures. You can also potentially have broader and have things that are a little more fine-tuned. So it'll give a lot more flexibility for that. And that is one thing in the law that we'll still be in a position to continue to do that, both in the law and in the agreements that we have with different folks. Here's an example on heart care in Virginia. We've been publishing this information for about 10 years. The hearts indicate 3 hearts are really good, 2 hearts are as you would expect, and 1 heart is not so good. With the all-payer claims database, we can get additional information on outcomes over time. This is what we have here is by hospital for mortality and 30-day readmissions. So we've been putting that information out there in one form or another for about 10 years or so. So with an APCD, you could get success beyond the immediate hospital stay. You could look at follow-up visits and other things. You get additional information on the costs associated with care that are being provided. that would be standardized and they'd be in fashion that would help people understand the difference in resource utilization and consumption, as well as how well people do over time. There's about 70 measures, 60 to 70 measures online today on Virginia HMOs. These are roughly called HEDIS. Some of you are probably familiar with HEDIS or CAPS. They're measures that look at the performance of health plans. We marry that information associated with premiums per member per month and other things associated with health plan margins. So this is limited to HMO performance. Now, there's over 1 million people that are in HMOs at this very time in Virginia. So that's significant, but it doesn't include all the other different types of plans. So with an all-payer claims database, a number of these measures that then can be run all the way across this Commonwealth of Virginia, so you could get a much broader picture. Even beyond that, if you happen to be in a physician practice, are there any doctors here today? Doctors here today? Okay, well, I'm still going to talk nice about them, okay? Because we have a great deal of respect for them. But doctors, it's not unusual for them to get one performance plan from one health insurance company shows that they're doing really well, another one shows they're not doing so well, and then another one they're doing sort of in the middle. Well, that could be a little frustrating. But on average, they were okay, right? Well, that's not good enough. So by crossing this across all different health plans and using the same measures, you can get a much better picture of both a doctor and a hospital's total performance. So that's a big deal, and that's the way that APCD could be used, a difference on resource utilization and quality of care, something that cannot happen today. This is nursing home information that we have that ranks nursing home stuff, and I don't have anything to say about APCD stuff on that, but I just like the slides, so I just thought I'd show it to you. Okay. All right, so what is an all-payer claims database? A little background. I know that when I looked at everybody else's slides, everybody's talking a little bit about a background of APCDs and how it's going. So by the end of the day, you should have a little checklist you'll understand, because we're all going to tell you in 3 or 4 different ways. It's made up of claims, and those claims could be from Medicare, from Medicaid, from federal health programs, from self-insured plans, from commercial plans, or others. You can look at health system performance using an all-payer claims database. You can look at focus on public health efforts to reduce the burden of care across the population. You can have public reporting, which is, of course, what we do. And again, as from Stephen's thing, the Joint Commission did recommend establishing that in advance of the 2012 General Assembly. This is the type of information that's typically in there, so we'll just put a little meat about this. Essentially, there is an encrypted Social Security number that is generally used that is reported by the plans, and the purpose of that is so you can link all the various claims together. You don't have names, you don't have other things, and this stuff is very sensitive, very protected, something we're absolutely used to dealing with. Demographics, birth, gender, relationship between the different groups, type of product, type of contract, diagnosis codes, procedure codes, revenue codes, service dates. These are things that are all associated with submission of a claim by a healthcare provider and then payment information on it. It's a very comprehensive set of information. It is light on clinical information, it's heavy on administrative data, demographic information, and what was done with the patient. Across the nation, there's about 14 all-payer claims databases, and these groups are set up differently. And most of the time in healthcare data reporting, it all depends on the state and their involvement in different things. So you can see that for these different states, you have one that's purely a state health data organization formed for that. State health departments are intimately involved. You can see Virginia down across. This will be through on the authority of the Virginia Department of Health with overall responsibility for this and quite active involvement. Sometimes governor's office and others. Also then with a 501c3, that's us, along with another state has involvement. So essentially the Department of Health has the authority, and the VHI is in a position where we're helping to execute that through the authority that the Department of Health has. Some ways we're the agent, but they're also very strongly involved in the process. So you're probably getting the idea that this could be used for a myriad of different things. And the answer is yes. APCDs can be workhorses. They can be used for a lot of different things, but you have to understand what their limits are. They don't have clinical information, but they have very strong information about the services that are being provided, both the utilization. Many quality measures have to do with utilizations, and sometimes they can be proxies. The utilization measures are proxies of our quality care. How often do people have foot checks? How often do they, when they have diabetes, how often do they have certain tests performed if they have heart failure or different things? How was the management of people with depression? How often do they see their doctor and others? So these things can be a proxy for quality. There's standards of care that are there, so they can be used for that. So it can run across really for consumers, employers, and all those for those different things. For researchers to look at care and the provision of care over time, as well as how it varies, and for policymakers and others. So again, something for everybody. So I want to move in and give you an example on how these are being used in a lot of states. And what we have is about 10 different conditions. And I'm going to see if this works. So this is in the state of Utah where they have an all-payer claims database, and they've essentially broken down the expenses that they have into different conditions. So at the very top, you'll see catastrophic conditions, and the green is the percent of healthcare dollars that are spent in the category, and the red is the percent of Utah residents that have that. This is not dissimilar to what you see in some cases where you see 80% of the expenses are by roughly 20% of the people. And that varies a little bit by condition and even by state. But what you can see is if you look at this, is most of the expenses have to do when people have chronic diseases, 1 or 2 chronic diseases. So in this case, in Utah, they found that 21% of the residents are using 53% of the different resources. Well, wouldn't that be a place you'd want to focus in for your company or for the state or others to try to address those? First of all, to prevent those conditions, but then keeping them from exacerbating after they're occurring. Now, you can also see 3 or more, but it happens so seldom that it doesn't represent such a high part of care. So in Virginia, where are your costs going? Does anyone have any distributions that they're currently using for this? Is there? Wellness programs are built around understanding of these different things and the drivers associated with this. So that is what an all-payer claims database can do. Now, very, very large companies do have access to information. Sometimes they'll have multiple payers and it's not being put together. The all-payer claims database offers that to put that together. Other mid-sized companies don't have access to this information or others because they don't have the resources to build the warehouse associated with this. With an APCD, it's being built. So the potential for access will be there. Another example, this is a prevalence of certain conditions, and this is in New Hampshire, and this is looking at different things about back, depression, diabetes, and other different things, and it's showing those over time, the distribution of those different cases. So you may be curious, how does your company compare to those? Are you spending that level of the cases per 1,000 employees? Are you higher or lower? What is driving that? Certainly a business that's involved in moving a lot of different things may have more back injuries. Other groups may have other things. If you happen to be a financial services corporation, you have a lot of depression. No, I was kidding. Just kidding. Okay. Just talking about the stock market here lately. But the simple fact of the matter is things do vary, and they can vary based on your interventions. So the APCD allows you to look at that information. Preventive services. This is something that if you have a wellness program, and the employers here associated with wellness programs, do you have those? Yes, no, maybe? Still eating cookies? Okay. Well, you can look at the percent of your members that have different types of tests, and then see if you can align your wellness programs associated with those tests. Here's a distribution showing a small area analysis in which you see a higher cost per care for certain areas. So potentially by region that can be done on a utilization of services by region and others. All things for an all-payer claims database with proper steps for confidentiality has the potential to do. Let's see, one of the last ones, this is something that shows a distribution of different measures by year, the access to quality and care. It's sort of a report card on those. This is the Medicaid one, but that could also be developed for some or all employers. You could do it by plans. You could do it by provider. And finally, the shift over time in the different types of drugs, be it the brand, generic, specialty, and others. And there's a slight shift going on, so they may be in position, if you're monitoring this, to look at why are the use of brand drugs going up? Is it because there are new drugs? Is it because of new prescribing patterns? If it's not a concern at all, but then you can put the utilization as well as costs associated with that for your employees. So how is the information being made available? So a number of states have public use files. These are databases that are there. And that's very handy for researchers and other folks that are working with you and others to look at information. So the public and then limited use files, those are sort of HIPAA terms that talk about the level of detail that's in there. The websites, special reports, and others. So there's some notes associated with it. In Virginia, we're looking to potentially have files that could be available, extracts of the database, a public website through VHI.org. Other folks would obviously use that all. And then special reports, custom reports that will design, other reports designed in concert with the Department of Health and with employers and others. So there's going to be an opportunity for interface with us to develop things that are of value to you. So the bill was passed, administered by VDH, contracting with VHI. Health plans, they may voluntarily submit the information. There's about a dozen plans that we're currently engaging in this process. The Act specifies the type of information that will be collected. It's very specific and reported. The Commissioner there's been a report that's been given or in the process of being given to the General Assembly about the status and the progress, which has been very significant. The funding of this will be, health plans will be paying 40%, the hospitals 40%, and the VHI 20%. We're at the point where the participation agreement, which bound those groups together, has been signed. We have all the submission and all the other related documents have gone out, and we're in the process of finalizing those documents. Most of them are finalized, and we're looking for the next couple of weeks for them all to be signed. At that point, then we'll be moving forward again. We're executing the agreements with folks. The funding will begin roughly 30 to 60 days after that. We'll be developing an RFP and RFI to bring folks together to help us in selecting a vendor. We had an advisory committee that Debbie's going to get into a little bit that we'll begin meeting with. And we'll be selecting our vendor, then be in a position to start receiving the information, start developing the preliminary reports. The way these things typically do is when the data first comes in, it's a little rough around the edges. And you work with the different folks submitting the data to identify areas in which things are not specific, or things are too specific, or things are just wrong, and then you refine those. So you start out taking broader swaths of the data, and then you fine tune and get it as the data quality gets better. We expect nothing less than that. The health plans are very committed to this information. They want to use it themselves. So we're pretty excited about it. And I'm not going to be Debbie Gondry today, okay, but we'll bring her on.
I'll be her.
Okay, you'll be her.
Thank you, Michael. Sure.